So we'll start with the first talk by Dr. Asrik Mukhopadhyay. Are you here, Dr. Asrik? Yeah.
Good afternoon, everyone. Today I shall be presenting a case series on accidental impacted large organic foreign body in the orbit with survival of eyeball and vision.
Ma'am, please.
I have no financial interests. Now, as we all know, intraorbital foreign bodies are a common complication following ocular trauma. Foreign bodies may be lodged within the walls of the orbit and cause damage to the eyeball and surrounding ocular structures. Here we present a series of 8 cases where all of the patients had a retained intraorbital non-metallic foreign body after trauma with preserved vision in the affected eye. Our objectives were to evaluate the surgical outcomes of removal of the retained intraorbital foreign bodies, to assess the pre and post-operative vision, ocular movement and lead excursion, and to look for any recurrence of orbital cellulitis, infection and pus formation in the orbit. This was a prospective non-comparative interventional study of 8 cases over a period of 1 year. All the 8 patients were of the pediatric age group with mean age being 8 years. Meticulous history taking is necessary to determine the exact mechanism of injury and the nature of the orbital foreign bodies, and then we perform the radiological imaging, namely non-contrast CT scan and MRI of the orbits. The pre and post-operative visual acuity, extraocular movements and eyelid excursions were recorded. The management outcome and long-term prognosis was studied for a follow-up period of 6 months. In this series, the orbital foreign bodies were all in the extraconal space, with 3 being in the superolateral quadrant, 1 in the superomedial quadrant and 4 in the inferolateral quadrant. Here we can see one such patient with an orbital cellulitis following an intraorbital foreign body in the superomedial quadrant of the left eye. The axial view of the MRI shows 2 parallel hypointense shadows in the medial orbit. The patient had a history of an injury with a wooden stick, so probably the wooden stick upon entry and impaction in the orbit got broken into 2 parts. The coronal view of the MRI shows the same in the superomedial orbit, and this is the view of the sagittal section. This is another patient of a history of a date palm thorn injury in the inferolateral orbit. We can see the coronal section of the CT scan showing an hyperdense shadow in the inferolateral orbit, and this is the view of the sagittal section of the same patient. The preoperative localization of the foreign body was possible due to the meticulous radiological examination, and subsequently all the patients underwent minimally invasive orbitotomies for the removal of the foreign bodies. The mean length was 30.5 millimeter of the removed foreign body, and in all of the cases the foreign body was accurately located and removed. Thankfully, the visual acuity remained unaffected in all of the patients, and all of them regained extraocular movement completely and LPS action post-operatively. Here is a short surgical video of 2 such patients. The initial surgical site is marked upon the proposed incision. The skin and subcutaneous tissue is incised by radiofrequency knife. Then the orbicularis and the orbital septum are dissected, and we enter into the extraconal space. Blunt dissection is carried out, not too aggressive, and upon reaching the foreign body by feel or by visualization, we remove the foreign bodies in toto. In the left we can see the wood, bamboo thorn, the date palm thorn that was removed from the inferior orbit, and from the right side we can see the 2 parts of the wooden stick that got engaged in the superomedial orbit. Subsequently, wound toileting was performed, thorough saline wash was performed to remove any debris, and the wound was closed in layers. The initial incision, the initial entry site was remained unsutured. Orbital foreign bodies are more commonly observed in males and in younger patients, and thus pose significant diagnostic and therapeutic challenges. It is essential to determine the location, number, size and type of material which significantly affects the management and potential complications. The clinical outcome also depends on the severity of the inciting trauma and the time duration from the injury. In this series, thankfully, the clinical outcome and anatomical and aesthetic appearance of all the patients were highly satisfactory. Thus, the take-home points are that if the foreign body is metal or glass, and if small size, it may be asymptomatic and may be left in situ and observed following conservative management. However, if the material is any organic matter like wood or vegetative matter, it elicits an intense inflammatory reaction and it needs to be removed urgently. Thus, it is essential to early detect the location, the size, the number and the type of materials, as this affects the further potential complications. And if the material is organic foreign body, the early surgical intervention needs to be carried out, And we should have the patient on regular long-term follow-up, as the complications may occur even months later. These are my references, and I thank you all for your kind attention.
Thank you, doctor. It's a nice presentation, but I would like to add something.
Yes,
Actually, ask. First thing, why you say all metals can be left behind? What's your idea behind it?
No, madam, I'm saying if the metal foreign body is small in size and it is not causing significant side effects, it is
No.
not causing any traumatic neuropathy, it is not causing any, I mean, chalcosis or any siderosis, then we can observe, and if necessary, we can remove, because the surgical procedure also has some complications. If not necessary, we shouldn't aggressively perform surgery.
No. I want to ask you the rationale behind it. See, why we can leave behind a shelter or some particles from a rifle or bomb shell, but not a very dirty nail inside? The rationale behind it.
There might be the clostridium infection, and there might be the subsequent infective particle. If it is the gunshot injury, there will be high velocity injury, and as a result the any type of infective material or organism which might be present will get sterilized. The metal particle will get sterilized, and thus it might not cause a significant inflammatory reaction.
So I think you should modify your reasoning that only maybe gunshot or a bomb blast, high velocity, very high volatile material can be sometimes left behind.
Okay.
Very rarely, pellets, etc. But you cannot generalize as it all metal foreign bodies.
Yes, madam.
And secondly, sorry, one more. What is better, MRI or CT scan for wooden foreign bodies?
For wooden foreign bodies, ideally we should both the non-contrast CT scan will show a hypodense shadow in the region of the orbit, but in the MRI I don't think we can accurately see, so I'd say CT scan.
And about glass?
About glass?
Yes.
Glass, both, I think MRI will be ideal for glass. I'm not sure.
Sir.
No.
Okay, so I just wanted to know two things. What is the maximum time period between the presentation and or the injury and the time that you intervened?
Actually, the patients are being referred from the distant centers, so we intervene as soon as possible. As soon as the patient were referred to us, they presented to us, and then we could get our anesthetic workup done as soon as possible. For the minimal anesthetic workup needed for emergency surgery, we intervene. But in this case series, the maximum intervention was done within 5 days. The maximum 5 days.
And what is the mean period? I mean, most of your cases were...
most of your cases were within 3 to 4 days.
3 to 4 days. And what is the longest follow-up you have?
We have done follow-up for 6 months.
So we move to the next presenter, Dr. Holly Dhanuka. Is she present? Okay, she is not here, so we'll move to the next one, Dr. Saujanya, largest case series of fish hook injury. I would request the presenters to please stick with the time, that is 5 minutes. Otherwise, we'll not be able to conclude on time.
Good afternoon, everyone. I'll be presenting largest case series on fish hook injuries. I have no financial interest. Engaged both as an occupation and a pastime, fishing boasts a widespread popularity across the globe. Penetrating ocular injury with fish hooks is usually uncommon, but if it occurs, it is associated with corneal lacerations, traumatic cataracts, choroidal hemorrhage, vitreous hemorrhage, retinal detachment, and endophthalmitis. Usually, fishing-related ocular injuries are underestimated and underreported. This case, we aim for to underscore the imperative of recognizing fishing-related ocular injuries, acknowledging their potential severity, outlining the successful surgical approaches for their management, and promoting preventive measures to mitigate visual impairment. This is a retrospective study and done for a period from 2003 to 2023. All the patients with fish hook injuries were included. A total of 21 cases were included at the follow-up of post-operative day 1 week and 1 month, with 3 months follow-up and every 6 months after that. Most of the patients presented with the age from 9 to 59-year-old with a mean age of 29.4 years, and most of them, 90.4% are males with 9.6% females, and 85.7% are from rural coastal areas, and time of injury to the presentation is less than 12 hours in 61.9%. 80.9% were open globe injuries, and 14.3% are blunt trauma. Barbed are seen in 6 patients, 8 are barbless, and 3 details are not known. Second surgery has been done in 10 cases out of 21. Corneal transplantation was done in 2 cases, cataract surgery in 3 cases, vitreoretinal surgery in 3 cases. After poor initial best corrected visual acuity, presence of infection at the time of presentation, delayed presentation beyond 12 hours, and retina and vitreous involvement at the time of presentation were found to be significantly associated with poor visual outcomes. Safe removal is always challenging. Incorrect removal can create more damage to the ocular tissues. So for the proper removal technique, we should know the basic parts of the fish hook, which is eye and shank. It has a bend, barb with the point, and a fishing line. Fish hooks can be divided into barbed and barbless. Barbed based on the number and location of barbs, single, triple, and multiple. These should be noted because these details are very important to determine the best removal technique. Methods of fish hook removal are back out method. This is backing out the hook through the entrance wound. This technique is a simple technique, and this is usually used for barbless hooks. And the second method is cut it out technique. A small incision is given with the scalpel blade at the entrance wound, and then sliding the scalpel blade along with the hook to the point of fish hook. After this, fish hook is simply backed out as a simple back out method. This method is used for the barbed hooks. This is advanced cutout method, advanced and cutout method. This is a photographic documentation from AIOS et al. Group. Here we cut the barb from the bend with the sterile wire cutters, and then back out the remaining fish hook. Needle cover technique, this is used for the fish hooks in the posterior segment, passing the needle bore, large needle into the eye through the hook entry, and then engaging the barb into the lumen of the needle and withdraw both together. The other is snatch technique. This is a modification of back out technique, but this is used in the non-ocular tissues because it is a traumatic technique. Downward pressure of the hook on hook shaft and rapid extraction are used to diminish the pain during the removal. Conclusion, our study highlights the significance of comprehending the anatomy of fish hook and applying a suitable technique for its removal. It is important to know the type and structure of fish hook and plan its removal accordingly. Professionals involving fishing activities must wear the adequate personal eye protection. A public self-advertising campaign in multiple languages is important to sensitize the public on eye care during fishing and related activities. These are my references. Thank you.
Thank you. It's a good presentation and very nice videos also. So how many cases you have done personally?
I did only one.
Okay.
This is like a 4 cent. We have collected the data from 4 centers.
Okay, multi-center study.
Multi-center.
And ethical part? Ethical clearance part?
It is cleared from.
Okay, sir.
So I had two observations. I mean, first, when we were talking with the conclusion, you're talking that the technique of the removal is fine. So have you done any inclusion of this technique in the statistical analysis or the outcomes? No, because when I'm concluding something, I have to base it on the statistical analysis or something like that. So have you done that?
No.
The type of the technique? No. The second thing is that you're talking about a very important point that you said is that many of these cases are coming from rural settings and coastal area. And have you done any studies on the microbiology of these areas? Because there is a resurgence of what is called as ocular melidiosis, right? So Burkholderia, Pseudomyeli, and all those things, which were most of the times, because this is an EPO conference we're talking, most of the times it used to be in Bangkok and Thailand, but now it is visible in the coastal areas, Andhra as well as Kerala and all. So have you done any microbiology studies, or did you end up getting some samples of some organism? Did you note any organisms there, or all of them were clean?
Some of the infection, they are infected, but we didn't get any organism like.
Okay. Anything?
Thanks.
Thank you very much. That's excellent.
So we move to the next one, Dr. Bhagavat Nayak. Dr. Nayak.
Yeah, I have uploaded the new one. Today's review room I have uploaded the newer one. This is the old. This was sent 1 month back already. Not there.
Hmm. In the meantime, can we have the next presenter, please, Dr. Dhwani Agarwal, till the time Dr. Nayak is sorting out his presentation. Dr. Dhwani's presentation. We'll have Dr. Nayak's next. Dr. Dhwani Agarwal presentation.
Not yet started.
आप किनका लगा रहे हैं प्रेजेंटेशन? मैम का लगा रहे हैं ना? तो यहाँ पे तो डॉक्टर नायक का आ रहा है.
So if Nayak is there, then you can.
So good afternoon, everyone. For those of us who have come across a case of intraocular foreign body in open globe injury, we know that it is just not a vision-altering situation; it's a life-altering situation. So we'll be going beyond the surface today and delving into the outcomes of intraocular foreign body in open globe injury. The range consists of 16 to 41%. So for every 5 open globe injury, the chances are that 2 cases will have intraocular foreign body. And if left unchecked, it could lead to severe inflammation, endophthalmitis, blindness, and thereafter phthisis. So we at LBPI did a study to find the significance in deriving the visual outcome based on mode and location of injury, time of presentation, time of intervention, basically to see the determinants which define which patient sees and which patient suffers. So it was a study conducted in GMRV campus Vishakhapatnam of LV Prasad Eye Institute. It was a retrospective observational study of 115 patients of 121 eyes. We did an elaborate exercise on patient demographics, injury details, clinical findings, surgical intervention, visual outcome, and these were the results that we were able to find out. This was a study of 115 patients with 121 eyes. The average mean age was 37 years, mostly young male of 19 to 40 years, and the average mean time of presentation was 24, although the median was 2 days. So to our surprise, most of the cases that we came across came in the later half of afternoon or later in the weekend, and about 3/4 of these injuries were workplace injury, out of which 50% were due to hammering or chiseling. If we look at the univariate analysis impacting the visual outcome, we saw, although statistically insignificant, but there was a contribution of corneal penetrating injury and non-metallic foreign bodies. there were more anterior segment findings as compared to posterior segment, and involvement of retina and endophthalmitis played a significant part in deriving the final visual outcome. So the mean best corrected visual acuity at presentation was logMAR 1.66, which nears to legal blindness. And if we look at the final best corrected visual outcome which we were able to attain was 0.98, which is moderate impairment. Running the multivariate analysis of independent risk factors, we were able to find 3 independent predictors for poor visual outcome, that is poor best corrected visual acuity at presentation, retinal involvement, and patient presenting with endophthalmitis. Looking at the logistic regression of independent risk factors for predicting traumatic endophthalmitis, although the location of intraocular foreign body did not have much significance, but involvement of posterior segment finding was very significantly associated with incidence of traumatic endophthalmitis. So if we have to concise the results, looking at the demographics and workplace safety, occupational hazards associated with high-risk labor mandates the use of protective eye care. If we look at the timeline, there are 2 perspectives here. From the patient perspective, the more number of cases presented in the later half of the day or later half of weekend, that could be because of fatigue, work-related stress, increased workload that could lead to increased injury rate. And from the healthcare perspective, there has to be greater vigilance and preparedness during this hour because this is the high alert time and high influx time of the patient. Looking at the IOFB composition, there were more number of metallic foreign bodies that presented to us, but non-metallic foreign bodies were associated with higher traumatic endophthalmitis, almost double of metallic. And 3 independent predictors of poor visual acuity was first, poor best corrected visual acuity at presentation, presence of vitreous hemorrhage, and retinal hemorrhage, retinal involvement in terms of tear, detachment, or dialysis. And the presence of posterior segment findings was associated with traumatic endophthalmitis irrespective of the location of IOFB. So if we have to conclude the study, we can come to 3 P's: preparedness, protocol, and prevention. Prevention in terms of using protective eye care, eyewear in high-risk occupational settings. Protocol, if you're suspecting a non-metallic foreign body, start antibiotics early. If you're suspecting vitreous hemorrhage, retinal involvement, prioritize surgery. And preparedness in terms of if more number of healthcare professionals allotted in afternoon or during weekends where there's going to be high influx of the patient. Thank you.
So what I'm not getting is that what is your take-home message particularly? Because if I say this study we have already done many times before, many generations.
What is like?
So what is the
what's
difference
originality?
here?
So one take-home message is about the timeline, ma'am, that there are going to be more patients during afternoon and during weekends. So there has to be a mental preparedness amongst the healthcare workers. And the second is the difference in endophthalmitis presentation. So normally metallic foreign bodies will be associated with endophthalmitis, but in our study it goes against more of the studies that say non-metallic foreign bodies are not so often associated with endophthalmitis as compared to metallic foreign bodies.
See, most hospitals run a 24/7 emergency. So if manpower, I don't think is a crisis here. But the point is that have you actually done the prognostic factor according to your OTA score?
Yes.
And how is it?
The prognosis?
Yes, according to your OTA score?
We were, according to the visual outcome, we were able to,
Yes.
so all the patients here went for surgery within 2 days. And we were able to attain good visual prognosis for all these patients. But additionally, what we saw that if there's an additional intervention that was associated to any of the patient, that also led to poorer visual prognosis for these patients.
Sir?
Again, was there any microbiological thing that you found? What was associated with the non-metallic and what was associated with the metallic?
We haven't come to the difference between metallic and non-metallic, but if I tell about the endophthalmitis cases, predisposed, most of the cases that we came across were gram positive, followed by gram negative, as we often see.
And what are the sensitivity patterns in your area? I mean, wouldn't that be able to guide the future, when you do your second audit, you would know the sensitivity patterns from the first audit and then make the instead of an empirical antibiotic, you would
We
probably
can do
not have an
that.
empirical, but
Yeah,
you
it will
didn't do
be,
the sensitivity studies.
we haven't moved that much.
So I think one thing that I would like to add is it is very important that when you are exploring a trauma case, you always take either a AC tap or the wound swab. Something you have to take because ultimately you are going to start this patient on steroid. Okay, if you don't take a swab or something from the eye while repairing it, you might actually land up into endophthalmitis. So that is one of the very important thing. So it might happen that your metallic cases actually had some superadded infection. It depends upon the time that the patient are coming.
So all these cases went for culture sensitivity of intraocular foreign body. If AC tap was done, that AC culture sensitivity, and if vitreous tap was done, vitreous culture sensitivity.
They were has what sir was asking you, right?
So did you come, what would your recommendation be? So suppose I say I'm coming to your institute and I'm doing a foreign body removal. What would your recommendation be on what particular antibiotic and what would that be based on?
So
you would
if
say
we,
use this antibiotic.
if we suspect a traumatic endophthalmitis in cases of open globe injury and we have excluded intraocular foreign body for that patient, we go for an empirical treatment that consists of voriconazole, amphotericin, and itraconazole.
So have you noted fungal infections in your cases?
Yes,
Is that what you're trying to
they were
tell?
pretty less. I cannot recollect the number, but yes, they were there, that too.
Fine. So we'll move to Dr. Naik's presentation if it is loaded. He'll be talking about management outcome of post-traumatic glaucoma due to tennis ball injury used for playing cricket.
So good afternoon all judges and respected faculty and their colleagues. So my topic is slightly interesting as usually nowadays all are playing with tennis ball for playing cricket in gully, mohalla or in community. So we can see from this video that when ball throws at speed of 140, 150 kilometers speed, so it can hit head along with the eye, and even with the helmet you can see how the damage that can occur. So these are the famous cricketers. Some have lost their life and some lost their career due to the severe eye injury. Most of the you know. So what is the difference actually? What is the tennis ball? This is the softer category marker. This is the softer category. This is green ball, which weight is 56 gram only, and this is the leather ball. The weight is 155 gram, and this tennis ball give high bounce, and this leather category the less bounce. So nowadays the young adults they choose this red tennis ball actually. That gives the true bounce, and the weight is nearly equal to leather ball, and so that's why the velocity and mass that ultimately lead to momentum. Momentum can damages the internal structure of the eye. So you can see that in any community they don't use the helmet while playing this type of tennis ball for cricket, but the same intensity of the regular cricket. So we wanted to do a study as we got some patient retrospective study in glaucoma clinic from January 2023 to 24 to see the management outcome of blunt trauma due to tennis ball injury. And all the patients registered in the OPD and glaucoma clinic were screened. We took the patient which only with the tennis ball and that means post-op at least 6-month follow-up. So we got a number of patients, 6 patients, and 3 were betters and 2 were fielders, and 1 was even bystanders. She was just watching the play. And mean highest baseline pressure of 42.5 mm mercury, visual acuity had movement close to phase 618, and all had angle recession more than 180 degree. 4 had a hypema, 1 was full hypema, which were denied later, and 1 was with subluxation of lens more than 120 degree with vitreous flush into AC. 2 had posterior pathology, and medical management did 2, and 4 we took for the surgery. So this was a surgery, trabeculectomy with simple MMC, and 1 was Ologen, another with trabeculectomy failed. After that we took AGV, followed by cataract surgery. Then another was cataract surgery, CN fixation of IL, followed by TRAV, then followed by blame needling, as that was TRAV was failing. So out of 6% vision improved in 5% significantly from presentation. IOP also reduced 16.2 mm mercury with 3 absolute success and 3 with qualified success. 1 patient did not improve with persistent low IOP and has also retinal pathology, visual acuity PL plus, PR inaccurate, and post-op. So these are the medical management cases. You can see that the 2 cases were there. I have to put 1 photo. You can do 270 degree, that means sphincter tear, and both needed 4 medication in the beginning. And after 6 months, after the inflammatory was recovered with 2 medications, mean IB was 16.5 millimeter mercury. And these are the surgery case. First case was the TRAV with simple MMC. This case was with after irrigation aspiration of the hypema. We have to do the TRAV with Olagen, and after that the IC was shallow, and there was some CD. And but after 1 month, that is good. That means CD was resolved with IFP was 10 millimeter mercury. This case, after failed TRAV, we had to do a AGV. After that, cataract formation. Then we have to, as the case was persistent low hypotony, we put a 5-0 Fluorine suture in the tube, and we have to remove the IOL, but still we could not save the eye. That saved the eye in persistent hypotony with the peer inaccurate, because it had also posterior pathology. And this was the cataract case with subluxation of more than 120 degree. You can see the vitreous prolapse into the eye. So we had to do the IOL, that means lens aspiration with vitrectomy with shunt fixation. Then IOL placement. Then after that second setup, we did the trabeculectomy, which was failing. But after with 1 bleb needling and with 1 medication, the patient is following with good 624 vision with IOP control. So what the closed globe injury ball? It can, as you know, that there are 7 rings. It can damages from the anterior segment to the posterior segment with all the rings, as you know, the iodialysis, cyclodialysis, hemodialysis, and at last retinal dialysis. So from this study, what clinical implication this carries this study? I want to just present, say the message is that as nowadays mostly playing with tennis ball. Patient with blunt trauma with tennis ball are to be followed regularly for the development of glaucoma. And management posterior glaucoma due to this tennis ball also is a complex procedure, as it need to handle lens, vitreous, retina, and may need multiple intervention also. And the message to the community should be take precautions, proper precautions while playing cricket using a well-fit helmet, because the helmet has various types also, which has the nose bro that cannot prevent the injury even with a soft tennis ball. And the bystanders should be a safer distance, should be vigilant. So that is my message, and this is our team. So thank you.
So what was the average duration that the presented to you?
Sorry, ma'am. Average duration.
Duration you did the surgery.
Duration as our tertiary center, most of the like from neighbor states also, like from our Bhubaneswar, West Bengal also, they presented with just after 2 months. But once the hypema cases they presented early, we did hypema drainage, and after that also we did angle decision there. But average what 2 to 3 months.
I'm asking the duration between the AC
acid tap.
Acid
tap and glaucoma surgery.
Yeah.
Acid tap, glaucoma surgery. As the eye was not controlled even after 1 month with all the medication and Dimax, so we had to take surgery.
See, I would like to ask you one thing. As ma'am already asked, see, angle recession, the glaucoma doesn't develop so early. It's somehow, how many times you have got angle recession glaucoma just after the injury and the development of glaucoma, that gap period? Because angle recession is a late finding.
Yes, it is a late finding.
Yes.
But in our cases, most the medical management cases, we did not. That means surgery was not needed. That high IOP was due to the inflammations, because not only at the first angle recession, but the other inflammation factor maybe. And the hypema was the vitreous prolapse. The cases was case was not resolving after 3 months. So that was with angle recession. There vitreous was also in the antechamber. And another case that with the AGB, that was a long-standing cases of 6 months.
First thing, because as for our knowledge, ankle recession is a long-standing complication, not immediate complication.
Yes, ma'am.
So, what is the duration of the injury and ankle recession you got?
Yes, ma'am. Ankle recession, what I written in later book, that it can from 90 days to 9-10 years, up to 9-10 years, it can develop also. But in my opinion, after 3 months, it will present, ma'am.
So you got your first case after 3 months?
First case, hypema cases within recent cases. Other cases are after 3 months.
So that could be red cell glaucoma or inflammatory glaucoma and not an angle recession.
Pardon, sir?
So that could be a red cell glaucoma or a
Exactly,
hypema-related inflammatory glaucoma.
that is what I was
not an
thinking.
angle
Yes,
recession.
ma'am.
Not necessarily
I
ankle
mean,
recession.
I am not saying that angle recession the only cause. I am not saying that.
Yeah.
All had angle recession.
Huh.
Because that all are blunt trauma, so all had angle recessions. So if the angle recession is more than 180 degrees, then that chance of glaucoma is more, 70% chance of glaucoma is more. But all the glaucoma is not due to only angle recession.
Exactly.
Yes, that I agree.
So there are two more things that I wanted to ask. Have you done any statistical analysis with all of these? Any odds
Sir,
ratio?
age were 6 patients,
Small.
static
Okay,
analysis,
so
Small
I
group.
think
vision
some
only
odds or
improved
something
that
like
with
More
variety
like
of patients,
Most like
and
case
I have
reports,
to go only the tennis ball, the
Tennis,
red
okay.
tennis ball. So I want to
There's
message that
another
only.
thing is that when did you do your gonioscopy assessment, or were you doing it on anti-segment or OCT, or what is it? After the imaging. So how were you diagnosing your angle recession at what time?
Sir,
I mean, when were you putting your
yes, sir, yes.
gonios-
Gonioscopy, if the patient is coming after 2 days, trauma 1 day, 3rd days, we don't do actually gonioscopy, but
Absolutely.
written, because it will dislodge the clots, etc. But other patients are like after if patient coming 1 month, 2 months, 3 months, then you can do gonioscopy. Sir.
So were you doing an anti-segment OCT or something like that?
Anti-segment OCT we
You
have
look for
not
the
done
angle
in
recession.
this case. we
Okay,
have
fine.
not.
And the last thing was, did you look for cyclodialysis cleft or
Cyclodialysis cleft, sir, 1 to 2% there, but there is minimal.
okay? And traumatic reserve loss. I mean, did you
Yes,
see
sir.
traumatic reserve loss? If you pull my hair, suddenly I will become bald in particular areas. So did you look for traumatic reserve loss in the retinal fiber layer?
Retinal, 1-2% is posterior pathology. That was that means retinal thinning was there, and one is vitreous.
Commercial retina. Did you see commercial retina and then associated?
Commercial retina, no, that patient was with retinal thinning already had come, and one is vitreous hemorrhages.
Thank you.
Sir, I have one thing. So don't you think it can be related to optic nerve pathologies, the vision loss? That is what maybe to optic nerve had avulsion. Have you done any radiological investigation in relation to optic nerve canal? Because vision loss maybe because of that also, right?
I understand. Optic
Yeah.
nerve, because the 4 has no posterior pathology. That 2 cases who has posterior pathology, that optic nerve avulsion sign was not there. Anything we have not done actually CT scan, etc.
Okay.
Okay, ma'am.
So we'll move to the next one, Dr. Divya Tara. Is she here, Dr. Divya Tara? No. Okay. So next one is Dr. Harini Krishna B.
Wishing you all a very happy afternoon. So I am Dr. Harini Krishna, and I'll be presenting on corneal foreign bodies, a study from a secondary eye care center in rural South India. Our center is situated in a semi-rural area in rural South India. So our purpose of the study was to study the demographic details and the clinical features of individuals presenting with corneal foreign bodies to our center. So it was a cross-sectional study done over a 6-month period, and all patients who presented for the first time with the corneal foreign body were included in the study. Patients with penetrating injuries or conjunctival foreign bodies or open glow injuries were excluded from the study. All patients were subjected to a questionnaire which they answered, and the clinical features were noted by the ophthalmologist and recorded. So coming to the results, we had 119 subjects in the study with a 90% predominance of males. And it was seen that 52% of the subjects belonged to the working age group of 21 to 40 years, which meant that the corneal foreign body was leading to loss of manpower and money. So we wanted to look at what occupations these subjects were involved in. So most commonly they were involved in metal industry, which was around 44%, followed by construction industry, which was 15%, and agriculture around 11%. And the most common activity they were involved in while the fall of foreign body was found to be welding in 36% and metal grinding in 12%. And both of this were common in both the construction site business and also in metal work industry. So the most common material of foreign body, which was found to be metal, which was close to 54%, which is followed by vegetative matter, which is 9%. So patients who presented with a metal foreign body, 77% of them had presented with a rust ring. So when there was a rust ring, the patients had to come for multiple visits as well. And 12% of the patients presented with corneal infiltrates surrounding the foreign body, but almost all of those infiltrates were less than 1 mm, and they did not need any referral. And 20% of the subjects presented with old corneal opacities, which meant that they already had a similar history and they had come back with repeated injuries. So coming to the wearing of protective glasses, so only 19% of the subjects were wearing protective glasses during work. And when we asked them about the common reasons, they said that it was very uncomfortable for them to wear the glasses, and also there was non-availability of glasses at workplace. And 25 subjects tried to remove it by themselves. So what they used was, most commonly they used currency notes, and some of them used cloth and even fingernail to remove the foreign body. And also 44 subjects used over-the-counter medication, and almost all of them being steroid drops. And 14 subjects had used native treatment like breast milk, coconut oil, and one person had used hen's blood as well. So, and 2 subjects got their foreign body removed by a traditional healer who removed it with her tongue. But it was not removed, so she came back to us for the removal. And we also looked at any association between presence of corneal infiltrate and traditional methods or native treatment, but it was statistically insignificant. And we looked at the education level of the subjects, and it was also seen that 80% of the subjects were not even aware of the corneal body can cause any morbidity, and it was associated with a low level of education, and it was statistically significant. So to conclude, corneal foreign body contributes to eye-related health issues among individuals in working age group, which I already mentioned. It's causing loss of manpower and money and time. So this occurrence is mostly due to lack of awareness and also a low level of education. So what we can do is only promote awareness programs and ensure that there is availability of protective wear in the places where these people work. So what we wanted to do after the study is we wanted to start a dedicated counseling to patients coming to our center. Our center is a small one, so it was possible to give dedicated counseling to every patient who presented with corneal foreign body. So we tell them the risk and the importance of wearing protective glasses. Also, we started giving pamphlets regarding use of protective wear. And also, since we have regular workplace camps, so we also started asking the doctor to tell them wherever we go, not only to the workers, but also to the owners of the factories, to provide protective eyewears and also encourage the workers to wear protective eyeglasses. These are my references. Thank you.
Thank you. Especially, I'm liking the counseling part. Of course, that's a new thing. But how many you have got insect wing? Have you got insect wing foreign body?
Yes, madam. But most of them are, the insect wing is usually in the conjunctival form, upper tarsal conjunctival. We had taken only corneal foreign body, sir.
And how the eyes reacted to breast milk?
Ma'am, breast milk, it presented with severe congestion, ma'am. Severe congestion, but it's even for conjunctivitis, patients come with breast milk. It's a common.
Do you find any secondary infections like fungal infection with the use of the steroid? And
sir, to us it didn't present, sir. It's a secondary
no fungal infection.
Sir, there was infiltrate in patients, sir, but it was almost all of them were 1 mm or less. So we don't have a microbiology because it's a secondary center, sir. So we treated by ourselves, but we did not need any referral for these.
The use of the tongue and the breast milk and all. And,
no, so there were only 2 patients who presented like that, and they did not have an infiltrate.
So how many patients were having superficial corneal foreign body, and how many had
ma'am, when it was around 33% had superficial, and the rest had deep foreign body, which we had to remove with a needle.
With a needle?
Yes, madam.
No, but with if they were deep foreign bodies, how would you remove them with a needle?
Ma'am, if it were too deep, we would refer the patient, ma'am. If
okay,
it were
you don't have any person to
we don't have a cornea clinic, ma'am. So we have, it's a secondary center. So whichever is possible to remove by a general ophthalmologist, we would do it. If it were beyond our...
So here is something, I asked a question because I wanted to say 2 things. One, that sir was saying, it is very easy to set up a microbiology lab yourself, even in a secondary center or in a primary center also.
Yes.
You need minimal things from GRAM and KOH. This is the first thing. Second, every ophthalmologist should learn how to repair a cornea or a bone.
Yes.
I think that is 2 things everybody should know.
Yes,
okay.
Thank you.
Fine, thank you. So we'll have the next one, Dr. Harini R.
Good afternoon, everyone. I am Dr. Harini. I am presenting on ocular impact of Diwali, unveiling the spectrum of firecracker eye injuries in a tertiary eye hospital. Our objectives were to analyze the spectrum, clinical manifestations and outcomes of firecracker eye injuries during Diwali and to propose a comprehensive prevention strategy. We did a prospective observational study including all patients presenting with firecracker eye injuries during the week of Diwali. A detailed history including age, gender and circumstances of injury was obtained. Visual acuity and IOP was done. Slit lamp biomicroscopy and indirect ophthalmoscopic examination were done. The injuries were categorized into open globe and closed globe injuries based on Birmingham eye trauma terminology system. Specific clinical findings and cases requiring surgical intervention were noted and statistical analysis were done. 81 patients presented with firecracker eye injuries during that week, out of which 70% were children, that is 56, and majority were males. 26 had visual acuity of less than 6/60 in the affected eye, 8 had bilateral disease, and 6 had open globe injury. 9 had required multiple surgical interventions. Corneal tear was seen in 16%, epithelial defect with debris was seen in 39.5%, significant hyphema was seen in 34.5%, lens involvement was noted in 11.1%, periorbital or lid injuries were noted in 33.3%, significant IOP raise was noted in 2.5%, and evisceration was required in 2.5%. Firecracker eye injuries are preventable yet prevalent. Parija et al. In a study reported that it accounts for 20% of ocular trauma cases in India. Malik et al. In a study reported 101 cases, out of which 54% were less than 14 years. John et al. In a study reported 84 cases, in which 1 in 12 resulted in unilateral blindness. In 2022 Maharashtra, 69 people had irreversible vision loss during a single Diwali session. Firecracker eye injuries are diverse and vision threatening. The increased incidence of firecracker eye injuries causes severe and irreversible blindness, resulting in social and economic burden. Ultimately, it affects the quality of life. Parija et al. In a study reported vision loss in children adds psychological and social burden to the family and the society. They also encouraged public firework displays using protective glasses and the importance of public awareness. Vise et al. In a study reported is more common in young males, and bystanders are also frequently injured. Countries using restrictive firework legislation have lower incidence rates. And Diman et al. In a study reported that there is 52.7% reduction in firecracker eye injuries with strict legislation. So, uniform implementation of strict laws nationwide is essential. Pujari et al. In a study reported that after New Delhi's firecracker ban, most injuries were reported from outside the city, suggesting a potential impact of the ban. So, we proposed a multifaceted approach including A. Awareness. Promote awareness on potential risks of firecrackers and the importance of eye safety during celebrations. B. Barrier protection. Encourage using safety goggles as a barrier to prevent eye injuries. C. Control displays. Advocate for organized and supervised firework displays by trained professionals. D. Distance. Educate individuals about maintaining a safe distance during firecracker displays. E. Exploring innovations. Advocate for the use of technologically advanced, safer, and environmental friendly options. F. Follow regulations. Strictly adhere to regulations and guidelines to ensure a secure atmosphere for celebrations. For a better future. Firecracker eye injuries are preventable yet prevalent. This study highlights the spectrum, severity, and burden of firecracker eye injuries during Diwali. A multifaceted approach is essential to combat this festival epidemic to ensure a safer and joyous celebration to all. Thank you.
So I wanted to ask that what is your ultimate message about the study?
So ma'am, we firecracker eye injuries are so prevalent, and we wanted to re-emphasize on the magnitude and the clinical manifestation of the firecracker eye injuries, and more importantly, we wanted to propagate the multifaceted approach. Ultimately, we want to prevent those injuries. So we wanted to emphasize on that.
From your study on your conclusions, but have you drawn some conclusions from your study? Like example, the distance, maintain safe distance. So was there something which came on in your study that people who are far had lesser damage or better outcomes, people who are near? So you can draw that conclusion based on your study rather than literature. So
Yes,
was there
sir.
something like that you do in your study which pointed out something that the strategies would be based on your study? I mean, it can be based on study of all studies, but
Yes.
which is also right. But
Try to
in your
collect
study?
data, sir, but it was they were not patients were not sure about the thing.
Right.
So
And what
we will
particular type of firecrackers would you say that it is with the anar or with the what particular type of firecracker and worse injuries?
Yes, sir.
As a strategy, you would say maybe you want to prevent this,
Yes,
or
sir.
maybe you want to at least if you don't prevent all of it, don't use this. What age group was more involved? So what is it in your study that you would like to say from my study? This is what is important. So from your study, the spectrum,
Yes, sir.
in the age spectrum or the distance spectrum or the type of the firecracker spectrum. So what is it from your spectrum and what is it from your outcomes based on the spectrum that you would want to say as a part of deductions or what you deduce from your study?
Yes.
What would you say in one line? So was it lesser younger children, unattended children? What was it?
It was more common in the young males and children.
Okay.
So we wanted to emphasize on they have a long lifetime. So it is very important to prevent those children from those injuries.
So it's an epidemiology. So you would want to say that unattended children were more worse. They were closer by. So something comes out from your study.
Yes, sir.
So try to look at that. There will be something more there.
Yes. Thank you for the suggestions.
You mentioned specifically IOP. How did you measure IOP in this case? 90% of the times it's not possible.
Ma'am, whenever feasible only we measured using eye care. Other patients we were not able to measure.
Okay. And how many cases of lid burn you have got?
Ma'am?
Eyelid burn. That's a more common in case of firecracker injury in children. Eyelid and forehead portion burn. Especially surgeon mentioned another.
We didn't specifically calculate that.
Okay.
We'll include. Thank you.
Okay, fine.
Thank you.
So we'll have our next presenter, Dr. Siddharth Manju. Just quickly, I just want to ask Dr. Anant is here, Dr. Ashish is here, Dr. Shivangi Singh. Dr. Shivangi Singh, she is not here. Dr. Rishti Kumari, Dr. Pooja Jain. Okay, fine. So Dr. Shivangi Singh is not here. Fine.
Shall I start?
Yeah. Yes.
Good afternoon to all. Today I'll be presenting spectrum of laser light injuries and their clinical outcomes. I have no financial disclosures. Laser lights are highly directional monochromatic sources of light that are focused in a small area. They are used in disco lights and decorative purposes. September is a month of religious activities and increased laser light usage. Hence, more laser light injuries are seen in these months. We in our study documented 13 mutually exclusive cases in a month, and hence, as the frequency was more than that we had observed before, we proceeded with the study. In this study, 13 eyes of 13 patients who in the month of September 2023 had recreational laser light exposure were included in the study. 11 patients in the study were males, 2 were females. The mean age was 25.23 years and all patients had unilateral injury. Of all the patients, 9 patients had subialum hemorrhages and 1 patient had intra and subretinal hemorrhage. 1 had macular hole, 1 had a cyst at the macula and 1 had outer layer disruption. Of all the patients who had subialum hemorrhages, 3 patients underwent surgical management within 2 weeks of presentation, 2 patients underwent delayed surgery and 4 did not opt for surgery. This is the representative video for all the patients who underwent surgery, in which the patients underwent ILMP and using the reflux function of the cutter, blood was removed. In all the patients who had subialum hemorrhage, whether they underwent surgery or not, the hemorrhage resolved. But the ones who underwent surgical management achieved a vision of 6.6 and the ones who did not achieved a vision of 6.9. One patient had intraretinal and subretinal hemorrhage who immediately underwent intravitreal SF6 injection and at 5 weeks had complete resolution of hemorrhage. At 3 months, the patient had a small EZ and IZ loss and achieved a visual potential of 612. The patient with a macular hole did not undergo any surgery and at 3 months had flat open macular hole configuration with a visual acuity of 624. Patient number 12 had a cystic lesion and patient number 13 had a RP, EZ and IZ loss, which at 3 months all the OCT features resolved. But in the case of patient 12, the BCVA achieved was 6.9 and in the case of patient 13 was 6/12. This is the data regarding all the patients in our study. Laser light causes damage by the mechanism of photo disruption, photochemical and photothermal injury. RPE cells are at the forefront of the greatest damage and photoreceptors are damaged as bystanders. In our study, 80% of the patients had macular hemorrhages, wherein as the macula is very vascular, the choroidal and retinal vessels rupture and the hemorrhages are caused. And also when the peripheral retina is stimulated by the laser light, there is an instinctive turning of the head towards the laser light causing the laser light injury. Also during dark, the pupils are dilated. Hence more laser light is incident on the retina and thus it's more damaging during dark. Also in pigmented fundi, the energy absorbed by the choroid is more. The increase in the laser light injury that has been seen recently is because the manufacturing process is not regulated and the power output is much more than that has been labeled, and also a diffraction filter that is normally there is removed. Hence, the laser lights are more focused. Also, there is unregulated sale of class 3 lasers on e-commerce websites. These are a few screenshots showing that the laser light injuries are on the rise. In the end, I would like to say that laser light injuries are on the rise, and young adults and children are at the brunt of injuries. We need to act now more than ever, and there need to be stringent laws. Articles like these might have been published before, but its importance is understood by few, and hence its need. Also, by my article, it also needs to be known that it is not an exclusive laser light paper which like the ones that have been published before. Here you need to see at the frequency. Within a month, every other day, we're seeing laser light injured patients. Hence, the need of this paper. Thank you.
So why you specifically mentioned this month? Any particular reason
Actually,
for
ma'am,
that?
I related this month with, we've seen a pattern. Whenever there is a festival season, we started this paper in the month of September. So September in Karnataka is the time when they do the Ganesh Visarjan, that kind of time where there is a lot of dancing activities, a lot of decoration, a lot of laser lights being used. So we observed. Normally, what had happened is in the past previous years, we used to see 1 or 2 patients in a month. But this time, what we saw is every other day, 13 patients. If you see European studies, you see 7 patients in a paper that have been reported over a period of 1 year. Here, we got 13 patients in a month. There are other Indian papers also that have reported 30 patients, but that 30 patient is for a single event. What we are saying is that laser light, these projectors are in every other event are so damaging to the eye that this is turning out to be an epidemic. And also, as I showed an image of a projector, normally I was just, as this paper was being made, I just Googled it, how harmful could it be? I just typed on Flipkart or Amazon, I don't remember, there is a class 3B projector that is on sale freely. Even a kid can buy that for 5,000 something rupees. And class 3B, according to the classification, you shouldn't see it in directly. And even sometimes the laser reflections are harmful in these cases. Hence, the...
I think 2022 or something, we are getting some reports from Mumbai also, that Ganesh Visarjan period,
Yes,
and some reports from Dubai. Okay, so this is increasing, and before that we had a discussion so that all India-wise campaign should be done banning the laser. But how far it has got, I have no idea.
Yes, ma'am.
So have you calculated the incidence prevalence of this? Have you done anything?
Actually, sir,
haven't done that.
no, sir. It was just a
And
13.
second thing, you were saying that the power outputs from this thing and all. So of the patients who came in, did anybody look at what class they were? Like you looked up?
No, actually, the events were already over.
Over, so you did
And
no idea.
yes,
About that, right?
but these mostly would have been class 3B because every patient was like, I looked at the laser light, it came, it was very instantaneous for them.
And what was the longest follow-up?
It was 3 months for this paper.
The
We-
longest follow-up.
Yeah, actually we have these patients who follow up regularly because at Hubli we're the largest center and they trust us. So it was in 2023. So we still have these patients following up. And as the OCTs were normal, you see every patient had a normal OCT at follow-up. And 1-2 had EZN, photoreceptor loss. So then we didn't feel the need because the treatment was done.
Thank you.
So I'll invite the next speaker, Dr. Anand Bhosle.
Good afternoon, everybody. I'll be speaking and proposing a modified pediatric ocular trauma score as a novel scoring system in pediatric penetrating injuries. As we all know, ocular trauma is the second most common cause of referral for kids after strabismus in this age group. And pediatric eyes are just not a small adult eyes. There are so many problems with the pediatric eyes, because of which we always get a delayed presentation. Now, OTS is something which we all know, which was which is the standard of classification system by Ferenc Kuhn, and this has been being followed for adult with all these parameters being understood with a raw score, some with raw points, and whenever we have a certain score, the prognosis is understood. Now, because of in pediatric eyes, a different kind of classification was proposed by Akar et al., where they did not consider RAPD, and visual acuity at presence was not necessarily taken, whereas a score was considered from the rest of the points. So what is actually not considered in this pediatric ocular trauma scoring system is full thickness corneal tear, intraocular foreign body, and lens status. Either lens is dislocated or it is expelled out. So we decided to evaluate a novel modified pediatric ocular trauma system, which which will be used as an important tool for prognostications of visual outcome in pediatric patients. Whenever the kid is brought by the parents, they are always asked, "Doctor, will my kid see?" And this will be an all-encompassing scoring system where all the points, including the missed out points, will be considered. This was a prospective study for 2 years, and these were the inclusion criteria. Kids who completed 2 years of follow-up, 50 eyes of 50 patients were included in this, and visual acuity in logmar scale at presentation and at conclusion was noted. Location of the wound with respect to limbus and concomitant eye pathologies were noted. These were the parameters as per POTS, that is pediatric ocular trauma system. But what we considered in addition is full thickness corneal tear, intraocular foreign body, dense dislocation, leg dispulsion. Now, the most important point here is whenever we have full thickness corneal tear, we always get some kind of astigmatism and leading to amblyopia. Same with intraocular foreign body, it will lead to inflammation and it will cause a secondary membrane and those sort of things which have a long-lasting effect. And lens, of course, if the patient is aphakic, as we all know, amblyopia management is going to be a big challenge. So we incorporated these into this scoring system, and this was the scoring system added to the existing scoring system. Now, when we prepared the raw points of the summation, these were the modifications done. Higher the score, better is the visual acuity. Our study had 56% males and 44% females. Mean age of presentation about 7 years. And most common cause of injury was pencil followed by knife. So an interesting point here is again corneal injuries were 66%. Corneoscleral were 22% and scleral just 12%. So it's very important to note here that the corneal involvement is very important. And this was the distribution of groups as per the raw score sum. So 7 patients at presentation had no PL, and the highest visual acuity on log more than 0.2 was 9, which finally had come up to 13. So this was the graph of presentation at final. So 88% injuries involved cornea, and this is a very important parameter which has been missed by the primary ocular trauma scoring system. So we have included this the scores into a modified ocular trauma score, which can be the standard of reference for all our prognostication of pediatric ocular injuries. So now modified POTS has the previous ocular system plus full thickness corneal tear, intraocular foreign body, and lens status, which again translates to amblyopia. And this is a better and all-encompassing scoring system as compared to the traditional POTS, and it will help us to prognosticate better in long-term visual outcomes. These are references. Thank you.
Did you actually compare the study with a proper ocular trauma score? Any bivariate analysis or something like that?
Madam, we are actually continuing with the study now, and we are about to reach 100 patients. So in this, we did a comparison analysis with the previous this thing. This was the. Can you please show this slide? So we did a comparison with excluding these three, and we found that the main reason of loss of vision was one of this.
No. My question is that did you actually did the scoring in both the ways and compare?
Yes, madam, we did the scoring, and that is one of the statistics there.
But I'm not. Where is that part? Can I see it again, please?
Can you please show me the slide?
You can start the slide presentation. So you can start the slide. So the other thing that I wanted to know, what you put them into groups. So what are the basis of the stratification of?
So stratification was according to the scoring.
So why did you cut off at in a particular point?
So
did you
it was
that there was something.
It was according to the previous ocular transfer. We have a standard of comparison. Because sir, what importantly we saw is astigmatism is something. If a kid is left aphakic, now management of that is extremely important. Astigmatism. So that is why I included all these and then compared with the existing. So we compared both the previous and the old systems.
And your longest follow-up is again how much? Longest
2 years, sir.
2 years.
Dr. Anant.
Yes.
Average follow-up?
Sir, we made sure that this entire data has 2 years, and people who did not follow up, they were excluded.
Next. Can you tell them where to stop? Yeah, next.
Which one was it, Dr. Anant?
I'll just take it.
I don't think there's a comparison.
Yeah, there's no comparison.
No comparison between OTS and old OTS.
Sorry, ma'am. I think that slide I forgot to do. There's a comparison between the previous old OTS, pediatric OTS, and the new one.
Your patient as per the old classification.
Old classification
as per
the new.
That was
That was yes, ma'am.
Thank you.
Okay, thank you.
So we'll next have Dr. Ashish Markan.
Very good afternoon to all. So I'll be presenting the results of 27 gauge MIVS assisted scleral fixation of intraocular lens, an AIOS2025 guided study. So we know a number of suture as well as sutureless techniques for SFIL have been described, and amongst these sutureless methods have gained popularity as they bypass the risk related to sutures. Techniques such as Giamane's technique have gained prominence, however challenges related to the procedural complexity and steep learning curve it remains. So alternatively, a number of modified Giamane technique have been described. So we have also tried to do a 27 gauge MIVS assisted scleral fixation of intraocular lenses and try to look at the outcomes using AIOS2025. So the study assessed the post-operative intraocular lens tilt, the decentration and iris to IOL distance, and their impact on the visual and refractive outcomes. So it was a retrospective study, and the relevant preoperative, intraoperative, and postoperative details were collected. The preoperative data included the patient age, the gender, the BCVA, the intraocular pressure, the specular endothelial cell count, and a comprehensive anterior and posterior segment evaluation. Postoperatively, all these patients underwent an AIOS2025 using Anterion. The exclusion criteria included was the secondary glaucomas, the corneal opacity or the scarring, previous retinal pathology, or optic atrophy or neuropathy. So how did we calculate the IOL matrix? The IOL tilt was defined as the angle between the corneal topographic axis and the central axis of the IOL. The IOL decentration was defined as the distance between the fixation point on the corneal topographic axis and the central axis of the IOL in the cornea. And the distance of the IOL from the posterior iris was defined as the perpendicular distance between the posterior surface of the iris and the IOL at the pupillary margin. So postoperative data was collected, and any postoperative complications observed during the follow-up period were also recorded. A pars plana vitrectomy was done only in cases that were associated with posterior lens or IOL dislocation or an associated vitreous hemorrhage. An interior vitrectomy and a thorough port site vitrectomy was done in all the cases. Intraoperative surgical videos were reviewed to assess any complications encountered during the surgery. Necessary statistical analysis was done. So just a short video to show the technique. So after securing the infusion, 227 gauge trocar cannulas was inserted roughly at a distance of 1.5 millimeters in a biplanar pattern along the horizontal meridian, just above and below. So once this was done, then the IOL was inserted, and then using 27 gauge max grip forceps, that was inserted through the cannula. the haptic was held with the trocar, with the forceps, and the cannula was then shifted onto the trocar. Once the haptic was extruded, then using the heat cautery, the haptic was flanged. A similar procedure was done on the either side. And once we felt that the required amount of haptic has been flanged, then the haptics were tucked inside the scleral tunnel to achieve the perfectly aligned IOL. And the infusion cannula was removed. So it was basically more like a sutureless, flapless, glueless technique for scleral fixation of the IOLs. So now coming on to the results, a total of 39 patients were included with a mean age of about 34 years. Male to female ratio was 29:7. Most of the indications were the dislocated or the dropped IOLs, phacodonosis or subluxations, posterior lens dislocations, or previous surgical aphakias. The pre-op mean BCVA was 0.85, pre-op mean intraocular pressure was 16.6, and the mean endothelial cell count was 2400. At 3 months of follow-up, the mean BCVA improved significantly from the baseline. IOP and endothelial cell count was more or less similar with no statistical significant value. So now coming on to the important aspect of the study, that what were the AIOS2025 measurements. So the IOL tilt in degrees was roughly 3.58. The IOL decentration in millimeters was 0.22, and the posterior iris surface and the distance of the IOL from the posterior iris surface was about 0.76 millimeters. So now if you go and review the literature, about 5 degrees of IOL tilt and about 0.2 to 0.3 millimeter of decentration is clinically tolerable to the patients. And when coming on to the postoperative complications, so about 4 patients, they had an IOL tilt immediately during the postoperative period and they required a repeat surgical intervention. 3 patients had vitreous hemorrhage which resolved within a period of 1 month. And 2 patients had choroidal detachment which again resolved within 2 weeks with the use of oral steroids. Now the mean refractive spherical equivalent was roughly 1.14. That is that all of our patients had a mean hyperopic shift. And when we tried to correlate with the IOL metrics, we found that there was a positive correlation between the distance of the IOL from the posterior iris surface, though there was no correlation between the IOL tilt and the IOL decentration. So these are the graphs showing the correlation between the mean refractive spherical equivalent and the IOL metrics. So just to conclude that the 27 gauge MIBS assisted scleral fixation of intraocular lenses, they demonstrate a favorable outcomes in terms of IOL tilt and decentration, contributing to improved visual acuity and reduced postoperative complications. And utilizing AIOS2025 for postoperative assessment provides precise measurements of IOL positioning, aiding in the refinement of surgical techniques. So this is just a review of literature. We try to compare our study with other studies which have actually looked at the IOL metrics using AIOS2025 or UBM. So the IOL tilt was more or less comparable of what is existing in the literature, but IOL decentration was significantly lesser using a smaller gauge vitrectomy, smaller gauge sclerotomies. Thank you.
Next one.
Thank you.
Okay.
When the next patient is coming in, next person is coming in, I'll just ask one question.
Dr.
Did you correlate the posterior
Drishti Kumari?
distance to uveitis or CME and something in the did you correlate the distance from the iris, the IOL distance, and iritis and CME and things like that?
No, patients developed CME.
Okay, great.
I think it seems very easy to do it and much lesser time than making the flap and putting the flap. So I think the time duration is less. You have done both, I think, but
10 to 15 minutes. But the important point is that how do you hold these haptics? You need to hold them with the maxillary forceps just at the tip. Otherwise, you might break them. And the second advantage of using this technique is that even if you feel that your IOL is slightly decentered, you can always gauge the amount of flanging you have to do, rather than creating just the scleral flaps which are always fixed at a particular position. Here you might flange the one haptic slightly more than the other to avoid the decentration.
Dr. Ashish, how do we use the trailing haptic? Because generally in these cases,
Yeah, so what I do is I usually use this maxillary forceps and I insert the trailing haptic just over the iris. Okay. And then I make a...
While you are injecting with the injection,
leading haptic is inside, the trailing haptic is opened outside the eye. Once you have
within the section only.
Yeah, it is outside on the sclera, means outside the wound.
Outside the wound.
Yeah. So now once you have extruded the leading haptic, now comes the trailing haptic.
Yes.
So you take a maxillary forceps, you bend it a bit, not the haptic, and you insert it over the iris surface, on the iris. Then you make a MVR entry on the opposite end. Then you use another maxillary forceps,
Okay, so
hold it.
two forceps.
Yeah, you bring it here inside in the plane, and then using another max grip forcer, using a shake hand technique, then you explain it. That's what I wanted to know because the trailing aspect, it's a main challenge.
Fine.
You need two forcers for that.
So let us go to the next talk for Dr. Drishti Kumari, please.
Good afternoon all. Myself Dr. Drishti, junior resident from AIOS2025-Free. My topic is approach towards retained periocular foreign body. It was a retrospective study at Tertiary Eye Care Center at Bihar. There is no financial interest or no conflict of interest. Ocular trauma is a common occurrence in our daily practice, and the retention of a foreign body within or around the globe is a significant complication following trauma. And this condition is more frequently observed in males working outdoors. Periocular foreign bodies can be divided into metallic or non-metallic. Non-metallic further divided into organic and inorganic. Due to challenges in locating and identifying these foreign bodies, a thorough clinical examination combined with radiological investigation is essential. Clinical assessment should include the identification of an entry-owned evaluation for granuloma formation, presence of acute or a chronic discharge, cranial nerve functions, ocular motility, cranial nerve sensations, and both anterior and posterior segment examinations. Organic foreign bodies are poorly tolerated and typically necessitates surgical removal, whereas some metallic foreign bodies may in some cases left behind. Periocular foreign body present as a small entry-wound discharging sinus, intraorbital mass, orbital cellulitis, drooping of eyelid can be found. Lid or conjunctival mass, diminution of vision. Clinical sign may be present as inflammation, tenderness, lid edema, erythema. Visual prognosis depends on mode of injury, site or size, and intensity of injury. My aims and objective was to know the cause and mode of presentation and treatment outcome of traumatic retained periocular foreign body, and to rule out possibility of a retained periorbital foreign body in a case of alleged history of trauma. My study design was retrospective observational study. It was a hospital-based case series occurred at RIU IGMS Patna of a time frame in 3 years. Patient reported in emergency or OPD within a day to 6 months of initial injury with possibility of retained periocular foreign body. Informed and written consents were taken, history taken, and clinical examination were done, and diagnosis was done with the help of imaging like X-ray, B scan, CT scan, MRI, and MRI of brain orbital including paranasal sinuses. Patients were managed conservatively, medical management followed by surgical exploration, and patients were followed up to 6 months. My results and observation were most of the cases was male, that is 73%, of age group 6 to 25 years of age, and the maximum clinical presentation were 47.82 were lacerated lid injury followed by discharging sinus, painful localized swelling, orbital cellulitis. Most of the foreign body were wooden stick, stone chip, followed by plastic, glass particle, bullet, or we can say mixed glass plus plastic. Cultures were positive in 9 cases. Most of them were gram-positive cocci, mainly cones. Complication, 2 patients found scarring as a complication. These are my representation of clinical presentations, types of foreign bodies. In case 1, we found stone chip as a for retained in periocular foreign body. In case 2, we found wooden thorn as a retained foreign body. In case 3, large wooden fragment of 2.5 into 1.2 into 1.5 centimeter were found in CCT brain orbit. In case 4, multiple glass particles were found. It's a case of a RTA in auto accident. In case 5, we found non-healing discharging sinus and non-healing orbital cellulitis. A plastic foreign body of size 4.1 into 1 centimeter was found in a non-healing periocular foreign body. Non-metallic foreign body example wood are radiological diagnostic challenges due to their varied appearances. So thin sections in CT or MRI scan is much needed. USG may not detect wooden foreign body due to their interference of gas. On CT, we need thin slices because foreign body may be mistaken for air or a fat. or maybe misdiagnosed. MRI scan should be performed after a negative CT scan if an intraorbital foreign body would be suspected. So take home message, a good clinical or radiological examination with surgical exploration and medical management under good microscope is the key for management in order to offer individualized and directed treatment to each patient. Coming to discussion part, some foreign bodies that are retained within the orbit and eyelid can cause immediate complication, whereas other are asymptomatic and remain undetected for a long period of time. Therefore, a detailed history is crucial in patients and should include specific questions about antecedent trauma and its details, especially in patients with soft tissue complaints. Depending upon the material of foreign body, it can be well tolerated without causing any visual disturbances. If patient presented with either discharges, sinuses, orbital cellulitis, localized swelling, non-healing wound, high index of suspicion for retained foreign body should be ruled out. Good clinical radiological examination along with surgical exploration and medical management under good microscope is the key for management. These are my references. Thank you.
Thank you so much.
Thank you.
Pooja Jain. Is she there? Dr. Pooja Jain. So Dr. Shivangi Singh is not here. I'll just announce the name once. Dr. Divya Tara and Dr. Holly Dhanuka. Three absent.
Good afternoon, everyone. I'll be presenting my paper on spectacle-associated trauma, retrospective analysis of visual and clinical outcomes. Coming to the introduction part, the incidence of ocular trauma in Indian population is around 4 to 7%. If we talk about the impact of trauma, though the ocular trauma affects usually one eye, not resulting in a blindness per se, but the impact of trauma in terms of per person loss of work hours and the psychological effect of losing one eye is enormous. So WHO predicts that by 2050, around 52% of the world population will be myopic, and so there is an impending risk of increasing spectacle-induced trauma as well. At present, the worldwide incidence is around 3 to 7% of all the ocular injuries, but there is a paucity of literature in Indian setting. There are concerns with spectacle-induced trauma because it can convert a blunt trauma into penetrating trauma and can induce multiple stellate tears at the same time due to shattering of glasses. So, keeping all these things in mind, we did a retrospective analysis of 11 eyes in our center where the trauma was inflicted with patients' own spectacle glasses or frames, and the parameters evaluated were demographic factors, mode of injury, extent and severity of injury, surgical intervention, visual and tectonic outcomes. The open globe injuries were classified into various types and the zones as per the ocular trauma classification system. Coming to the results, out of 11 patients, 9 patients were male and 2 were females, and they were almost equally distributed amongst all the age groups. And coming to the primary mode of injury resulting in broken spectacles, the fall was the most common cause in the old age group and the sports injuries in the young patients. Coming to the clinical presentation, 10 out of 11 patients had an ocular involvement, out of which 9 patients had open globe injuries, of which 6 had lacerations and 6 had zone 2 involvement. So the lens involvement was seen in three patients, and the posterior segment involvement was seen in 4 patients. Multiple tears were seen in 3 patients, and glass shrapnel removal was done from 3 patients. So coming to the visual outcomes, almost all the patients had good visual prognosis except 3 cases, case 2, case 5, and case 10. These patients were very severe cases on presentation and had a posterior segment involvement. None of our patients developed post-operative endophthalmitis. We had a wide variety of presentations. I'll be just discussing in a short some of our cases. This was a 72-year-old male who had a history of a fall followed by injury with his broken glasses. He presented to us with a juxtalimbar rupture with PCOL expulsion, and after the surgery, the visual prognosis was good. This was a young patient who had a history of a sports injury. He was playing cricket and had an injury with a cricket ball followed by the broken glasses. This was a 54-year-old male who had a history of fist injury followed by the injury with his broken glasses. He had presented to us with a rupture in a zone 3. This was again a female who had a sports injury. She presented to us with an irregular corneoscleral tear in the inferior quadrant along with a lens involvement. This was a very interesting case of 40-year-old male who was playing badminton and had an injury with a shuttlecock. He presented to us with two parallel tears in the inferior quadrant of cornea, where the inferior was full thickness and the superior was lamellar, as confirmed on anterior OCT as well. So while surgery, we planned that we'll only repair the inferior tear, but when we were repairing the inferior tear, the superior was opening, and the superior was opening, and that was also quite deep. And when we were repairing the superior tear, the inferior was also opening up. So we passed a continuous purse sting suture from both the tears together to help in the initial apposition of both the tears in the initial part of the surgery, which helped us in the subsequent suturing of the individual wounds separately. After the suture removal, the visual prognosis was good. This was a young child. This was a child who had a history of the fall, followed by the injury with his glasses. He presented to us with an irregular corneoscleral tear, along with a lens involvement. There was a tear in the lid also, and there was a tear in the cheek also. And when we were doing the cheek laceration repair, there was a broken glass particle that was removed from there. So this was again a child who had presented to us with a history of a hand injury followed by broken glasses. As you can see, he had multiple irregular tears in the superior and the inferior part of the cornea. So in this patient also, we had followed this purse sting suture technique to help in the initial apposition of the sutures, of the tears. So this was again an elderly patient who had presented to us with a globe rupture in 2 quadrants, and from the inferior part of the globe rupture, a foreign body was also removed. This was a very interesting case, a 23-year-old female who sustained a firecracker injury. She was a bystander, and her broken glass particles went and lodged in the cornea. So the broken glass particles, they were removed as they were involving the pupillary axis. So when we did the literature review, we saw we could only find the handful of the literature, and definitely there was a paucity of Indian literature. Normally we say the eye protection works, wear it. But does it really work? Let's just discuss a little bit about the impact resistance of glasses. Impact resistance is basically an ability of a glass to withhold a sudden shock before breaking. It depends upon the material of the glass, the thickness of the glass, the coatings. As we increase the number of coatings, the impact resistance decrease, the frame size, and the frame material. So these are the various materials which are being used in making the glasses, and at present the polycarbonate glasses are considered to be the most impact resistant. But considering the amount of trauma that we see in the emergency setting, the safety standards of all these glasses, they are not able to still withhold that trauma. So we have the American standards and we have the Australian standards, but we don't have the Indian guidelines as such. So to conclude, spectacle-related eye trauma is a small but preventable. It can convert a blunt trauma into penetrating injury and can also induce multiple tears at the same time. So whatever we have reported may be just a tip of the iceberg, as most of the time we just note the primary mode of the injury and forget to note the role of the spectacles also. And definitely there's a need of the REs to formulate the guidelines for the spectacle material, especially in the Indian setting, as the myopia is on rise, and so the spectacle-induced trauma as well. So this is a detailed data of our patient. Thank you.
Over here, due to paucity of time, we could not discuss the last 3 cases. I would request the speakers to come.